about everything you've been through over this last little bit. And I heard from Lauren, like, no family history of any of this. It's just crazy. And then genetics.
Yes.
So you spoke with your oncologist about kind of the fact that mutation does increase your risk of
Just
having...
before you go on, I want to record, but I'm recording myself.
Oh, like you want to just record what I'm saying?
Yes.
Oh, okay. Yeah, sure. That's fine. So they would have talked to you about the risk of associated ovarian cancer with the BRCA1 mutation. And so the recommendation is for having the ovaries out to try to reduce the risk of ovarian cancer. Now we take both the ovaries and the fallopian tubes, and then we'll talk about your uterus because I hear you want to talk about that. And that's because often we think that the cancer, if it starts in the fallopian tubes and then seeds to the ovaries. So taking out both fallopian tubes and both ovaries is the best way to reduce your risk. Now it's not 100%, it's a risk reduction, but it doesn't go down to zero. What we always do with this procedure as well though is before we even touch anything in your belly is we wash your belly down with sterile water and suck that water up to see if there's already any funky cells in your belly before we get started. And then we take both ovaries and fallopian tubes so that if there's a surprise funky cell on an ovary or tube, we know if it's already had a chance to go somewhere else or not. Now, typically that's all that's, I would say, really medically required. The BRCA mutations are not associated with things like cancer of the uterus at all. And so it's not needed that you take the uterus out. Now, remind me what our treatment plan moving forwards for your breast cancer is. Do they have you on tamoxifen or anything?
No, so it was triple negative breast cancer. So I'm done with everything. Including immunotherapy, radiation, the double mastectomy. I'm done with everything really. So it's just to reconstruct my breasts. And which brings me to another question, because they're supposed to take some stomach fat and deposit them here. So is it a surgery that can be done together?
So I would love to say yes. Often no, only because all of us have different days. So I always open up the door that if I can't book the tram flap reconstruction at the same time as mine, but if they feel like they could or it's appropriate, then they're always welcome. Like I can come and join their OR. But often we don't, because it's just it's recovery from both sides of things. And then the other thing is that when I do my surgery, I inflate your belly with air so that I can see all the structures, which obviously puts strain on the flap reconstruction that they do. So often we do them separately just to minimize complications for either or. But it sounds nice, right, to go under and just get everything done, fully tune me up, let's do it all. Now, especially not being on any kind of hormone therapy moving forward, I would say your risk of having a cancer of the lining of the uterus in someone who's otherwise healthy, your periods, are they quite regular?
Not yet.
Okay, were they regular before?
Yes, they were, but chemotherapy put me in menopause. So I just had a period last month, and before that, I think it was in February. And then before that was in December. But throughout last year, after I started chemo in February, there was no period up until December, then February, then August.
And that's very common with the chemo. Now, sometimes the ovaries rebound, sometimes they don't. At the end of the day, when I take your ovaries out, that puts you into a medical menopause. So you will definitely be in menopause at that time, and then it becomes a discussion between you, your oncologist, and myself about whether or not we want to put you on low doses of hormones for protecting your bones and managing any menopausal symptoms. Given you had triple negative breast cancer, they may or may not feel that is safe or not safe to do. And so that would be a discussion that we would have either before or after doing this risk reducing surgery. Now, not being on hormone modulating therapy like a tamoxifen moving forwards, tamoxifen can slightly increase the risk of there being just thickening of the lining of the uterus, but you don't have to worry about that. And the only reason I bring that up is when you ask, should I also have my uterus out? In general, I don't actually recommend that in this setting, because it makes the surgery a bigger surgery with a bigger recovery for no real benefit to you. But if you were going to have to be on tamoxifen and or Lupron or something like that, then there may be a benefit because of that risk of thickening the lining, but you don't have that risk. So personally, having a big hysterectomy surgery with 6 weeks off of work, no heavy lifting, no exercise. It's a more risky procedure. Like I said, the risks of that procedure aren't really outweighed by any benefits because there's no need for you to have the hysterectomy. Now, if you say, I lie awake all night worrying that my uterus is going to get cancer and it's causing me distress, well, then maybe there is benefit to you for that specifically, but I don't, from a purely medical risk perspective, I would say, like, in general, no, I wouldn't take out your uterus. I would say just ovaries and fallopian tubes. It's a day procedure. That's all that you would need, and that's the best benefit for you from a risk reduction perspective moving forwards. But we could talk about it if that's something you felt strongly about.
So my question would be about the uterus lining thickening, getting thickened. Like, what are the implications? Will I still have periods since you're taking out my ovaries?
Yes, so when we take out your ovaries, you will not have periods anymore because there's nothing to generate the hormone that causes you to have periods. So you won't have thickening of the lining anymore. But like I said, if some breast cancer patients have to go on those medications, and those medications have side effects on the uterus. So for those women, sometimes I say maybe it's worth taking out the uterus so you don't have to worry about it, but you're not going to have to worry about that. Thickening of the lining on its own is not a big deal, but if it thickens and the lining is so thick it's not shedding regularly and it becomes abnormal, like a precancer or cancer, then that's why we care about it. So in the absence of ovaries eventually or any other therapy, which you don't need, the lining of the uterus should go down super skinny and not cause you any problems moving forwards in theory. So that's why like I said, I don't think that we would need to do that. What I would propose we could do, if you are open to it, is that we could do just the ovaries and fallopian tubes, but at the same time take a little look inside the uterus with a camera and sample the lining of the uterus just to make sure that it's all good, so that we know everything was fine when we took out your ovaries and stopped your periods. And then moving forwards, then we can decide if we're going to give you hormone back, yes or no, for how long, what we do, etc. Usually people don't go on hormone moving forwards because, again, just that there's that risk associated with it, but we could talk to your oncologist about what they see and see how your symptoms are moving forwards. The procedure I propose, removing the fallopian tubes and ovaries and then just sampling the lining, just that you know that everything is fine. It's pretty low risk. Risks of surgery are always there, though. Things like bleeding and a blood transfusion. If you were to need blood, we always ask if you needed it to save your life. Is that something you're okay with?
Absolutely.
Small chance of infection that we give you antibiotics before to try to prevent. Always a chance that we injure something else in your tummy, like your bowel, your bladder, the tubes that drain the pee from the kidney to the bladder. The only surgery you've had in your belly, I think, right, was the umbilical hernia, right? Yeah, so we would not go through your belly button. Normally I put a camera in your belly button, but we're going to put our camera way up here and then put some ports on the other side there. It's all done laparoscopically, so one little incision, one little incision, one little incision up here. We remove the fallopian tubes and ovaries after we do that washing. Then we put everything inside a plastic bag in your tummy and then take it out through that plastic bag. So if there were some funny cells, I'm not spreading them everywhere by smushing it in through the skin and everything like that. Other risks are the risk of blood clots. So anytime that you have surgery, you can get a blood clot afterwards. Now this surgery, it's about 45 minutes being asleep, and then we get you moving right away, and your recovery is really nice. You're usually up and walking lots. No crazy exercise right off the hop, but you can get back to your normal workouts usually within 2 to 3 weeks. But you're walking lots afterwards, so your risk of clot is super, super small.
Okay, so the question I have now is still about the uterus. Since I'm not going to have my fallopian tubes and ovaries, why do I still need to retain the uterus?
You don't need to retain it, but you don't need to remove it, I guess is the point, right? So you don't need it there, but do you need the risks associated with removing it? Not necessarily. Now, what I would say is probably reasonable. You never had an ultrasound of your pelvis recently, and so I wonder if what might be, because there's no super rush to get this done. Like, we should get it done sooner than later, but it's not like we need this tomorrow. So I wonder about getting an ultrasound done. You're going to think about it and kind of reflect on how much is your uterus causing you anxiety. Because if it's a lot and you're really worried about it, then maybe it is worth the risk, like I said to you. We'll get the ultrasound done, and let's just make sure that the uterus itself looks normal, the ovaries look okay, fallopian tubes like that, that we're not worried that there's already something going on that could change our indication to say that yes, we should or should not do something additional, just so that we know what we're getting into in your pelvis. And then we can have a phone call after that ultrasound, and then you can tell me, when you thought a bit more about everything we talked about today, how we feel about the uterus or not, and then we'll know for sure that we're doing the right thing for you and we get you booked.
Okay, so apart from the higher risk of surgery and longer recovery periods for the uterus, for the uterus to be removed, like what other risks are associated with the uterus removal? Yeah.
So I would say not really many. If you have your uterus out, some people think there may be a higher risk of things like prolapse of the vagina, but the vagina is suspended by many ligaments, not just the uterus. So I would say all in all, I wouldn't be too worried about that.
Okay.
And then it's really just that the surgical risks are higher. So higher chance of things like blood clot infection and blood transfusion and bleeding.
Okay.
And then depending on the size of your uterus, which we'll know a bit more based on the ultrasound, or if you have big fibroids or something like that, it may mean that we can't do it all through the minimally invasive way. And then it comes from healing too. And so there's always a chance that the top of the vagina has a complication like an infection, or it doesn't heal well from where the uterus came out of. And so if you have a prolonged healing course, I always tell people the risks of these things are small, like 1 in 1,000, 1 in 500, but it's not like it 1/1000th happened to you. It either 100% happened to you or it 0% happened to you, right? So these statistics are helpful, but on an individual level, I can't say if you will or will not get it. And if you do have a complication, I don't want you to ever say, oh my gosh, if I had known this would happen, I would have never done it. I would rather you say, I knew this could happen, I hoped it wouldn't, but it did, and I'm as okay with it as I can be because I felt like it was still the right decision for me. Because that's all we can do when it comes to surgical risk, is knowing that it could happen, but it's unlikely, but if it does, we have to be willing to accept that and not beat ourselves up about it.
Okay.
Now, what also exists though is that we could say, you may say, I've had a lot of surgery, there's a lot of stuff going on between, and then the breast reconstruction, the whatever. Let's just do tubes and ovaries now. Take a look at the uterus, make sure things are good. I'm not going anywhere. You're not going anywhere. Let's get our breast reconstruction done. Let's let the dust settle, start to live our life again. And then if we say, you know what, I am still worrying about my uterus. Maybe I want to talk about doing something about that. Of course, nobody wants more surgery, but I don't want you to ever feel like, well, I chose not to get the uterus out this time, so I'm stuck with it for life. You're not. We could always talk about doing that surgery at a later date.
I think that's a better option. So if we were to schedule this surgery, how soon can it be done?
Yeah, so typically what happens, if you're okay with either myself or my practice partner, Dr. Brar, doing the surgery, then usually we get it done. I'd say our wait list isn't crazy long. I think we're booking into mostly the new year now, so about 3 to 6 months out, which I know seems like a long time, but truly for a lot of gynaes it's not that long. We try to pick up extra time to keep our wait list low. But of course, if it's a hysterectomy, the surgical time is longer, so your wait is longer, versus just the ovaries and tubes. Like I said, it's only 45 minutes, so it's easier to fit that in. And then it would be sometime within probably the next 3 to 6 months, if not sooner than that. Like I said, all those risks exist. You could kind of think about them. I would still say it's probably worth doing an ultrasound preoperatively, just to make sure that we know what we see when we get in there. But if you think you don't want your uterus out, then I'm not too worried we're going to see too much of anything that's too wild.
No, so for now, I think I'll go with just the fallopian tubes and the ovaries, yes, not the uterus. Until I think the uterus can be deferred.
Yeah.
I don't think I'm too worried about it right now.
And I don't think you need to be worried about it right now. Truly. If I thought there was benefit to you, I'm very bossy, I would tell you. I'd be like, we need to do this. But I don't think that it's going to give you a lot of benefit. And like I said, if you're 1 in 1,000 that has the 100% complication of whatever, you're not going to be happy that we did it when you've already had so much happen to you and your body in the last little while.
Yes.
Now, so do you feel comfortable then signing the consent form for the surgery today, fallopian tubes, ovaries, and washings of the belly?
Yes.
And then what will happen is I send it, Katian does all of our OR bookings, so she'll call you within the next week or so and offer you dates. You choose what works for you.
I want to stay ASAP. I just want to be done with all of this.
Yeah, perfect. Yeah, so then totally. So you pick what works best for you, and then, like I said, we can continue to evaluate moving down the line, but I think you and your uterus, your uterus can live the rest of your days together.
If I had a magic wand, I'm just going to want to finish all of this surgery, the reconstruction and all.
I know, because it's been so much already.
Just finish it throughout this year and know that next year I'm free.
Yeah, no, I think that's very fair. You want to move on with your life.
Exactly. I just feel like a lot is being held over my head.
Yeah, no, and that's very fair. Now, are you seeing someone through the oncology clinic in terms of mental health supports?
Not at the moment. So I want to, but I also feel like it's not going to do so much for me at this time.
Okay, so you don't feel like you need it.
Yes, I just want to finish all my treatments before I start with that.
Yeah, no, that's totally fair. Now, I will warn you, so like I said, this does put you into a medical menopause. Now, from a chemotherapy perspective, we're kind of perimenopausal. So are you already having some hot flashes?
I was having hot flashes during chemotherapy, but not anymore.
Not anymore. Okay.
Yeah.
So you may get them again, and it may or may not last, or they may resolve. The other thing to be aware of is that often people get vaginal dryness when they get into menopause. So sometimes sex becomes more uncomfortable. If that's the case, though, there is treatment for that. So either hormonal or non-hormonal things that can go in the vagina that do not have any risk of problems with breast history at all.
Okay.
So we will talk about that and follow you for that, but I think it's important that you know that you may experience that, and if you do, we have things to try to fix it to make it better. Okay. So what I propose as a procedure is that we will do the washings, remove both ovaries and fallopian tubes, and that we're going to take a peek in the uterus and do the sampling of the lining at the same time, because like I said, that just gives you that extra reassurance that you really don't have to worry about your uterus. Now, are you comfortable with either Dr. Brar or myself doing the surgery? And it's okay either way. Like I said, she's the same. Like, we tell everyone we're twins, but we look nothing like each other. But we are the same person. More often than not, I assist on her days. So often I'm there, but not always. So it's if you're more comfortable because you see my eyeballs and you want to just off the surgery, that's totally fine. It's just that if you're open to either, then you may have a faster date.
Yeah, I'm open to yeah.
And then you can just decide based on the date. And I'm not offended either way, and neither is she. So it's whatever is comfortable for you is what we do.
Okay.
So this consent form is for all of that procedure, and then it just says also that if you were to need blood in an emergency to save your life, that's something that you're okay with.
Absolutely.
So this signature here, voila, is for the surgery. Goodbye tubes and ovaries. Beautiful. Oh, sorry, as I pull that away from you, sorry, I thought I had more space. And then this one is for a blood transfusion. Just wait, just hold on, there you go. Beautiful. So you can't wave a magic wand, but I'll do my best to wave my magic wand, okay?
Thank you.
My surgical magic wand. That's as best as we can do. Now, in the meantime, if you think of questions before your surgery date or you have any issues, then Heather will give you, do you have our card, like our business card?
No.
Okay, let me go grab it, and I'll just give you the extension to leave a message with Heather, who's our nurse, and then you can always just leave questions with Heather, and then she'll message me, and then I'll get back to you. Because I find sometimes if you try to book an appointment to ask questions, they'll give you one that's like 3 months after your surgery, and you're like, well, that's useless. So I just want you to make sure if you think about more questions, because obviously I'm sure if you listen to your recording or whatever, you want to hear it all again, then I want to make sure that you have a chance to ask those before we have surgery.
Yes.
Deal?
Yeah.
Okay.
Deal.
All right. Okay, we can 2 shakes with that card, and we'll set you free.
Thank
What do you do
you.
for work?
I'm a business analyst.
Oh la la. Okay. Are you working today?
Yes, I came from
tell
the
them I was
office.
really behind, and then go take a really long lunch and be like, she was super behind. Okay. Now, do you want us to, I guess, remove your IUD at the same time?
Yes, since I will not be needing it anymore.
Yeah.
When you say vaginal prolapse, is it weakening of the vaginal muscles?
Well, that's what causes it more often than anything. So that's why, there are some suspensory ligaments between the uterus and the top of the vagina, but I would say it's not such a high risk that but it is something that can happen, and having a hysterectomy does slightly increase that risk. That's something to be aware of, but I wouldn't use that as my make or break for why you have the surgery. Truthfully, yeah. Because you a lot of it comes down to other stressors. So if you're overweight, if you have chronic cough, if you've had 10 vaginal deliveries, all of those things are also related to that. So there's so many other things. So to say just surgery alone will or will not, it's hard to know in the context of everything else that's gone on in your life.
Okay, I've had 3 vaginal deliveries.
Yeah,
my
which
last
is the
was 8 years ago.
Risk factor,
My last one just turned 8.
Oh my goodness.
So
crazy. Boys or girls? What do you have?
all boys.
See, you don't have time to recover from a hysterectomy. That would be crazy. So option 2, then option 6 is for Heather, our nurse. So just leave a message, say I have this question about whatever. She'll send it to me. I call you back. We'll figure it out.
Okay,
Sounds
thank
good?
you, doctor.
Nice to meet
It was
you.
really nice to meet
And
you.
you'll hear from Katian probably within about a week.
Thank you
So
for your
option
time.
6.
Thank you.
My pleasure.
Okay. And that's a wrap.